Hi, everyone. Welcome to the South Asian Public Health Association Spotlight Series, a space where we highlight the leadership, impact, and stories shaping the health and well-being of South Asian communities across the U.S. We're your hosts, Samira, President of the South Asian Public Health Association.
And Anita, co-chair of the Education and Professional Development Committee. SAFA is an organization dedicated to advancing the health and well-being of South Asians in the U.S. and the communities in which they live, and has been instrumental in fostering research, advocacy, education, and collaboration to address health disparities and promote equitable health outcomes.
So last season, in honor of SAFA's 25th anniversary, we spotlighted the leaders who helped build and shape our organization's foundation. This season, we're expanding our focus. As the U.S. marks a historic milestone with its 250th anniversary, Season 2 celebrates the South Asian pioneers, researchers, clinicians, and advocates whose work has shaped South Asian American public health. From groundbreaking studies to community-driven initiatives and equity-focused innovations, this season reflects the wide-ranging impact South Asians have made and continue to make on the nation's health, while elevating the needs and lived experiences of our communities.
To open Season 2, we are extremely honored to feature Dr. Alka Kanaya, Professor of Medicine, Epidemiology, and Biostatistics at University of California, San Francisco, and founding investigator of the MASALA Study, the first and only longitudinal cohort dedicated to understanding cardiometabolic risk among South Asians. Dr. Kanaya is a practicing general internist whose research focuses on type 2 diabetes and cardiovascular disease, epidemiology, and prevention. Her work has fundamentally reshaped what we know about South Asian heart health in the United States and has informed national screening guidelines. Dr. Kanaya, it is our pleasure to welcome you to SAFA Spotlight Series.
Thank you. It's great to be here and see friendly faces.
So we're very excited to have you here with us today, Alka. To start, we want to ground listeners in your story and the path up to this work. You've shaped such a defining chapter of South Asian public health in the U.S., and so before the MASALA study began, what did your career look like? What drew you specifically to cardiometabolic health in South Asian communities?
Great. Well, that's the origin story. So I was studying to be a primary care doctor. I was a resident in primary care internal medicine at UCSF, where I've practiced since as well. And I was getting more and more interested in really understanding and investigating type 2 diabetes because I saw firsthand the devastating impact diabetes was having in my own family, as well as in the patients who I was caring for in the clinic and in the hospitals. When I was a resident, I started to kind of think about a career that wasn't a one-to-one caring for patient career, but more thinking about public health and being able to make broader changes in our understanding of health. And so that's when I was really just drawn to the field of diabetes. And along with diabetes comes heart disease naturally, because it is the most, I think it's the strongest risk factor for heart disease. And so when I started looking at, topics to research, I was drawn to people who've had careers building cohorts. So my number one mentor, my main mentor was Dr. Elizabeth Barrett Connor, and she has since passed. But she was kind of like the mother of diabetes epidemiology. She had a longstanding cohort called the Rancho Bernardo Study, which takes place in Southern California, San Diego area. It's mostly white men and women who she had followed in a cohort study for 3-4 decades and learned a lot about risk factors. It was kind of the Framingham of the West Coast, Framingham being from the Boston area. And so she had a lot of, great ideas for me to consider as, writing the first few papers, getting interested in diabetes. And one was looking at gender differences in diabetes outcomes, because there's always been this vague understanding of women catching up to the risk of a man when she has diabetes in terms of cardiovascular disease. So I did a few early papers with her about, gender differences. And what really struck me in the research is there were a lot of cohorts following, people over time, Mexican cohorts, African American cohorts, Native American cohorts, white cohorts, lots of white cohorts. And I didn't see anything like that for most Asian groups, including South Asians. And knowing that, oh my God, diabetes especially is so prevalent in South Asians. Like how could this not be something that is being done here or in other parts of the world where there are a lot of South Asian communities, or in India and Pakistan, Nepal, Bangladesh, Sri Lanka? Why aren't there these prospective cohorts really investigating the drivers of disease so we can understand how to change that trajectory? And so that was kind of like, a wake up moment, like, oh my gosh, this is like a big gap. And being South Asian myself and having, lived experience as an immigrant here, I thought it was really important to, capture the effects of, what happens to immigrants who come here and their health over time. And it, having a longitudinal cohort was just kind of like a no-brainer. Like, why isn't this being done? And that was kind of the start of an idea of like, we need this. This is an important gap to fill.
Alka, that is wonderful. Thank you so much for setting the stage. And so we're excited to kind of dig deeper into this with you. But before we go deeper, it is important to set the stage for those who may be new to MASALA. What is MASALA? What does it stand for? And can you explain the study and why was it important for you to, I mean, you've already explained a little bit about why you explained it's important for you to create it, but why now? And what other motivating factors helped you to move it forward?
Yeah. So the meaning of masala is a mixture of spices, as you all know, or a mixture of ingredients.
Yes.
But our study is fondly named masala purposefully. The acronym is the Mediators of Atherosclerosis in South Asians living in America. And I really wanted to choose a name that resonated with South Asians, so it could be something that people would like identify with quickly and understand. And I know a lot of non-South Asians have often called the study the MASALA study. And I'm like, what's marsala? Chicken marsala? Has nothing to do with South Asian culture. Anyway, so yeah, so that's the name of the study. So the study is a longitudinal cohort of South Asian Americans, so people living in the United States. We started the study in 2010. Since that time, it's grown to have over 2,300 participants who were recruited from 3 different sites: San Francisco Bay Area, where I am, Chicagoland area with my co-PI at Northwestern, Dr. Nami Kandula. And the third most recent site is NYU with Dr. Nadia Islam, who is also a co-PI for the study. So these 3 geographic sites are important because a lot of South Asian immigrants live in these areas, and we wanted to capture the diversity of people in these areas as well as of the different immigration waves to the United States. So what we've done in MASALA is purposefully try to understand not only individual level risk factors where a lot of medical and epidemiologic studies stop, but really to get to interpersonal, family, community, and societal level risk factors as well, to really understand like the mixture of all these in what goes to impact health and aging over time. So it's a longitudinal cohort where we bring people back every 5 years to remeasure different ways of thinking about risk factors, their heart function, how they're doing with aging. And we follow them every year with limited questions to see if anyone has developed heart disease or stroke, so we can start looking at what risk factors may have led to those outcomes. So it's a natural history study. We don't do any interventions. We give the participants their own data back so they can share that with their family, with their physicians, and raise an awareness about what these risk factors mean for them as well.
Yeah, I mean, I think anyone who has worked in South Asian health has heard of the MASALA study at this point, and it's just made such a big impact. And, going back to beginning and your origin, you talked about, what drew you specifically to this field, but was there a specific, clinical, personal, or community experience or story, that you could share with us that made you realize South Asians were being overlooked in heart disease, and that really was the kind of behind the scenes factor for launching MASALA?
Yeah, no, I think it was a confluence of many things. So my grandfather, he had diabetes and he suffered a lot of heart attacks as well as had heart failure and vision loss as a result of his aggressive diabetes. And so that was a personal thing that hit home, in high school. And I saw it and lived, how he lived through that experience and how it shortened his lifespan. And then, taking care of patients, just I think, anywhere you work in the United States, you will be surprised as a, medical student or someone in training, if you work in the hospital setting, to see the disproportionate number of South Asians who are coming into the heart wards, the cardiology units. It's crazy. And even till today, people come up to me and say, I saw a 35-year-old South Asian man who had the most most aggressive kind of heart disease or heart attack. And we couldn't believe it because he's only 35. Yes, we've all heard those stories. We all have been touched by those stories. And since then, that was like in the early 2000s, kind of making that connection during my training and bringing my family's lived experience into reality of what I'm seeing in other families as well. And then digging into the literature, like I said, and seeing that, a lot of people have described this. It's not a unique thing that we were seeing in the United States. It's been described in the 1950s in Singapore, in the UK, in South Africa. And all of the studies that have been done were really snapshot studies, right? Cross-sectional analyses saying there's more diabetes in the South Asian immigrants in this X country versus the other people who live here. And we don't know why. We assume it's, this or that. And there's no real like kind of digging into it and follow-up of people. And so that really, it kind of, struck a chord with me that we know a lot more about these disorders in general when we study broader population groups. We may be like seeing different parts of the elephant when we only study certain communities. And if we studied all communities, we'll get a better picture of that disorder. And for me, it was really focusing in on diabetes.
So I mean, it's really exciting for us to now kind of like dive a little bit deeper into some of the initial results that you may have, come across and discovered through this cohort study. I mean, as you mentioned, within the South Asian public health and so among health professionals, they're going to be already aware that South Asians often develop, as you say, and even among those of us who have family members who've suffered from it, South Asians often develop heart disease at a younger rate and at lower body weights, at lower BMI. So are there things that you learned from the first, initial results or even until now that this MASALA study has taught us about the elevated and sometimes invisible risk that surprised you or, that you did not expect, that you already knew or you didn't know going in?
Sure, sure. So, this thin fat paradox in South Asians has been described in the past, right? I mean, we all know the Yajnik Yudkin picture from the Lancet from 2004. If you're in public health, hopefully you've seen that photo of a European man and a North Indian man who have the same exact BMI. But if you look at their body fat composition with a DEXA, there's a big difference, 9% in the European man and 23 or 22% in the Indian man. And why is that when they have the same BMI? So we know BMI is a inadequate or incorrect measure of body fatness, and we've known that for decades. But we haven't really kind of, again, dug deeper into why. And so I think for us, we were excited to use, more advanced imaging technologies. We were already getting a CT scan of the heart to look at plaque in the arteries of the heart. So using that CT scan, we were able to look at fat around the heart, fat in the upper part of the liver. And also we did an extra slice CT to look at fat around the intestines and fat in the muscles. And what we found was there's very different body compositions in our South Asian group in MASALA compared to our comparator population, which is the MESA study that had 4 different US population groups. And what we found was South Asian have more fat in the liver, in the muscle, and around the intestines than those other 4 groups. and also have lower lean muscle mass. So there's like both a fatness story as well as the, low muscle story going on. And I think having those direct comparisons with MESA really highlighted how different and unique this profile of South Asians was. And that's something that I don't think had been, raised to the public awareness until we were able to really show that with this study that compared, Masala to the MESA population. So, and what we found since then is that having fat in these ectopic places where fat is not meant to be stored can really drive early onset of diabetes and heart disease. And so, what we're now learning more and more as we see genetic results coming out of our study, as well as the UK Biobank, for example, that has, 10,000 South Asians, is that there's a genetic rationale or genetic background to how people store fat. And so that is something we've inherited from our families is, our propensity to store fat in places where fat shouldn't be stored rather than under the skin. And that is something that we cannot necessarily change easily at this point, but at least we now can say that, hey, some of these things, it may be, your genetic background that is putting you at risk. But what can we change? And that is maybe, what we do in terms of the food we eat, the exercise we do, the stress we have to manage, and the, communities that we need to work with to help to, lower those risks.
Yeah, and I think one thing that's great about the MASALA study is that it also collects some of that data as well, right? So lifestyle data lifestyle in general is often oversimplified when it comes to South Asians, but MASALA study brings a lot of nuance and evidence. And so I think diet and physical activity is a part of the MASALA study that you are all collecting. So what findings from the study challenge common assumptions or stereotypes about South Asian lifestyle?
Sure. Yeah. So I'm going to talk more about the original MASALA study population. When we started in 2010 at 2 sites, we had 83% Indians in the study and very few Pakistani and Bangladeshi, Sri Lankans, and Nepalis. So primarily these diet findings are coming from those earlier studies. Currently, we've expanded the study to include over 600 Pakistani and 600 Bangladeshi populations, and we're just examining the diet data now of the new populations in Masala. And what we're finding is big differences in diet, right? In the original Indian population, about 40% are vegetarian and many are lifelong vegetarian. Whereas in the Pakistani population, it's about 2% who are vegetarian. And in the Bangladeshi, it's less than 1% who are vegetarian. So it's very uncommon. And so, again, that brings back the whole like aggregating all South Asians together is not a good idea. Just like we don't aggregate all Asians together anymore in public health, because we know that's a bad idea. We just can't see the nuanced differences, right? But what we found when we examined the dietary data on the original, Masala population was vegetarianism, though it's common, there are different diet patterns that these vegetarian and mostly Indians consume. And one was a very traditional South Asian vegetarian diet that included a lot of fried snacks, sweets, and high-fat dairy products like mithais and farsan. And everybody knows the types of snacks and foods I'm referring to. And then the second was more of a vegetables, fruits, legumes, nuts, and whole grains diet, a more prudent diet that's been described in other communities. And so when we look at the risk factors, they're really different. There's a lot more insulin resistance, a lot more diabetes and hypertension in that first, more traditional South Asian vegetarian diet, whereas there's very few risk factors in the other one. And so digging more deep into the data, we found that people who were consuming more healthy plant-based foods were less likely to develop diabetes over time. There was a reduced odds of diabetes, reduced odds of fatty liver disease. So, so that whole concept of having a vegetarian diet is healthy for you is not super accurate again, unless you really probe into what kind of diet do you mean when you say vegetarian diet? What are you really eating? And so that was a kind of an early, way of thinking a little bit more about diet and how we as clinicians may be asking about, diet questions.
Talking about factors that may influence our health, especially when it comes to cardiovascular health and cardio and diabetes risk factors, etc. You mentioned that you're not just focusing at the molecular level. You mentioned that you're not just focusing, that you're looking at even individual societal. There are multiple levels of. So we're excited to kind of dive a little bit deeper into that. Because a major strength of MASALA is its attention to the lived experiences, right? Not just biomarkers. So you talked about a little bit of this psychosocial factors that the study is also focusing on. So stress, discrimination, acculturation. How do you think these experiences show up in the risk for South Asians? And how did you, first of all, determine what factors to include? Because there's so many, and as you designed the study and the findings to go with it.
Yeah, no, I mean, we couldn't include everything we wanted to in the first pass, right? Because I mean, you can't keep people in the clinic and answering, survey questions for days at a time, although you want to. You have to be limited and prudent about what you ask. So we've layered questions over time, which is nice in a cohort where we can have a special study, like Dr. Kandula had a specially funded grant to look at social networks. So she was able to map social networks in the family and the kin, as well as the communities that people live in. So we're always trying to add more knowledge based on like what we think is an important area to pursue. So yeah, what we have found when we measured these psychological factors is that for women having high levels of chronic stress, so measured by 6 months chronic burden scale, that was independently associated with higher rates of atherosclerosis, a thickening of the walls of arteries in the carotids, as well as calcium deposits in the heart. For men, it was having higher depressive symptoms that was associated with atherosclerosis. And this is after accounting for smoking, cholesterol, diabetes, lifestyle factors like diet and exercise. So even above and beyond that, these, psychological factors seem to really be important. And we know that stress and depression and mood are linked to heart health. And it was eye-opening to see that, yeah, they're really very important, even measured pretty crudely with, our short surveys. Acculturation, I think acculturation is fascinating because it's a dynamic process, right? And so we are going back and remeasuring acculturation over time at baseline. In the original cohort, we measured acculturation with 9 different questions about who you are close to in your networks, the foods you eat, the languages you use, how you get your media exposure, and what language do you use to communicate. So we used 9 different measures, including traditional beliefs, to come up with an acculturation measure. And now, at 10 years after that original study started, we remeasured it because we want to see that, people change over time, right? But so when we did this latent class analysis of those 9 measures at baseline, what we found was there were 3 main acculturation strategies. Now, this type of analysis is nothing new that we created. This has been an analysis that came out of Dr. Berry's work in the UK in the 1980s, where they looked at immigration and the different types of acculturation patterns in the UK. And what we found was the most frequent pattern was a bicultural one called the integration acculturation strategy, where almost half of that original cohort were, bicultural in their beliefs and behaviors. A quarter were in the assimilation strategy, which is that they had adopted more American behaviors and norms. And then a quarter were in the separation category. So they had retained their South Asian cultural beliefs and behaviors and not rejected the American one. So those were the 3 strategies. And when we looked at, what happened, what risk factors these 3 groups of acculturation had, we found that the lowest risk people were in that bicultural, the integration strategy, or in the assimilation group, which is a real eye-opener and very different from other other immigrant populations like the Japanese that have been studied in other studies. The Mexicans have been studied in other studies. They found that the more you assimilate to the US norms and cultural beliefs, the worse your health in terms of obesity, diabetes, heart disease, everything gets worse, right? But we were finding quite the opposite in that assimilated group. And so why is that? Is there something that they are adopting in the American lifestyle that may be healthier than in their sending culture, in the South Asian culture? So that is kind of eye-opening. We're going to re-explore that now that we have the third wave of acculturation data to see if that holds up. And so I think there's a lot we can learn from that, not only about, an individual's own risk factors, but how they interact with, society and their communities.
That's fascinating to hear. And I think, given that the MASALA study's been around for 10 years, it's a long time. And you've collected so much data, which is fantastic. It's one of the first of its kind for the South Asians in the US. So long-term cohort studies often reveal a lot of unexpected insights, similar to what you mentioned right now. And a lot of this reshapes the field. So after all these years leading MASALA, what findings surprised you the most? And how did it shift your thinking about heart disease risk in our communities?
Well, I don't know if I can pick one finding because there are many surprises. There are many things that, but I can name two.
Okay.
One is that there are vastly different immigration experiences depending on when people immigrated to the United States, right? So with the Immigration Act in 1965, the earliest immigrants to the US were coming from India, mostly North India. And then there were waves of immigration that started later that were from Pakistan. And the more recent waves are coming from Bangladesh. And what we've seen is as the immigration laws have changed, the selection process of immigrants has also changed. So those early immigrants, as you all know, were only allowed to immigrate if they were coming for higher education or professional degrees, right? So as a result, the Asian Indians in the United States are a very high SES group, high education, high income. Other waves of immigrants who've come subsequent to that have come with family reunification and other immigration reasons that and don't have the same type of high SES as those Indians. And so what we're seeing is that is a big finding in terms of when we try to disaggregate the data by subgroups, because a lot of the Indians were those early immigrants that were selected with high SES, whereas the newer waves are not. And we have to be really careful when we compare across South Asian subgroups because of SES and education differences being large with the immigration patterns. What we're finding when we disaggregate the South Asian data and look at these three main nationality groups, if I can call them national origin groups, is that the Bangladeshis have the highest risk of diabetes. They have the highest prevalence of diabetes, of hypertension, and smoking. Second is the Pakistanis, and lower are the Indians. And so there's a kind of the stepwise function of these three groups. And when you aggregate them together, of course, you lose that because the largest group of people in most studies in the US, given the population differences in numbers, are Indians. And so you lose the nuance in being able to see that. What we're trying to do now is as we dig deeper into what is causing these differences, because these are not going to be genetic differences that are causing, there to be almost double the rate of diabetes in the Bangladeshis compared to the Indians. And this is also, on the background of the Indians already being much higher than the four MESA groups, right? So we're looking at a difference in tenfold differences for the Bangladeshis compared to the whites in MESA for diabetes. And so when we're digging deeper, we're looking at not only, the immigration reasons and the family and personal history differences in these groups, but also, dietary differences, stress differences, other psychological factors that may be happening with being a more recent immigrant, with other policies that are happening in the United States. So we have to kind of be really careful about this, because it could just be like, oh, socioeconomic status explains the difference in these groups. Well, I don't think it's only going to be socioeconomic status. It's going to be a lot more nuanced with many different factors. So we're in the middle of working through these brand new data. We just concluded that expansion study last summer. And so we've just started to, dig a little bit deeper, and hopefully by next year we'll have some of these findings out.
Yeah, fantastic. So, we've talked quite a bit about the research side of it, from your study design to the factors and the initial findings. And so I'm really excited, as you're a practicing clinician as well as an internist, to kind of talk a little bit about what the implications of these studies are for clinicians who treat South Asian patients, et cetera. So, your findings clearly have implications for how clinicians approach South Asian patients. Based on the MASALA findings, what changes would you most like to see in how the clinicians screen and counsel South Asian patients? And perhaps if you can also add a little bit about how South Asian clinicians themselves should also be approaching the results of these studies when they're treating their patients.
Yeah, great questions. So I think it's important that we raise awareness about this early and aggressive disease in everybody, including clinicians in general, but especially in South Asian populations, so they can advocate for themselves, or we can advocate for our families and our communities if they're not able to themselves. So, part of this is in having kind of an idea that clinicians may not understand that there should be maybe more screening done in South Asian populations, to dig a little deeper beyond the usual metrics we use. Like when we do, risk factor screenings, it's about weight, it's about blood pressure, and it's about, cholesterol and hemoglobin A1C. That's usually the extent of risk factor screening that is done. But I think for South Asians, we have to move beyond weight. Don't even, we're not going to stop at BMI.
Yeah.
I think it's really important for all clinicians to not only measure these standard risk factors, but to go beyond. And by that, I mean measuring an ApoB level, which gives you a better understanding of the overall cholesterol burden in somebody beyond LDL alone. So all of the atherogenic particles are captured with an ApoB measure that beyond LDL. Lipoprotein little a is a specific type of genetically determined lipoprotein that is more sticky and inflammatory than other lipoproteins, and it's not part of the panel. So LP little a should be measured one time at least. In a man, it can be done anytime in their life. In a woman, it's really important to measure that postmenopausally, because it changes a lot, premenopausal to postmenopausal. So if you get one as a premenopausal woman, get one again, 2 to 3 years after menopause. And that's important because that is, again, genetically determined, and we don't have a great therapeutic that brings it down, but at least you get an idea of, okay, that is a high risk factor for me, and I need to be even more aggressive about controlling the other risk factors I can. And then we also do advocate for people who are not already known to be high risk based on all these other tests, and they feel like everything is normal or just kind of borderline, that a coronary artery calcium test, which is a heart scan done in 5 minutes, that can give you more information outside of what you can learn from these other tests. And that's not a test that we do every year. That's a one-time test, and if it's normal, then you do it in 5 years again. And so these are the tests that I think every South Asian should have on the back of their hand, kind of like, these are the tests that I need you to order, and tell your doctor, educate your doctor if they don't know that this is something that, that is recommended for South Asians. The newer and newer guidelines, since 2018 have included South Asian ethnicity as a risk enhancing factor. And while I think that's important from a public health, awareness raising, I don't think that just your background should be the one making the call of you needing to start a medication, right? So I think that these additional tests really help to risk stratify people as high or low risk. Because in MASALA, we found that, not all South Asians are high risk. There are people who have really normal risk factors. And even though they're 100% South Asian, so it's not just like all 100% of South Asians will have heart disease. So we want to be able to risk stratify everyone so that they aren't necessarily, starting medications that won't benefit them. And so that's in terms of clinical tests. I wish all clinicians and all, people knew that these are the tests to ask for. And we want to make this kind of list of tests broadly available. And that's why we've been trying very hard to kind of disseminate through multiple channels. I really strongly encourage people to see the Brown Heart documentary. It's a docudrama that several of our investigators helped to, give input on to make, relevant to South Asian communities.
Yeah, and I think the Brown Heart documentary talks a lot about this as well. And so we'll include a link to it in the captions when we publish this.
Absolutely.
And then you also talked a little bit about this, but beyond individual care, MASALA has important implications for population health and national guidance, right? So what do you see as the potential public health or policy implications of this study? And what are some of the challenges or limitations in translating the research into practice at a population level?
Yeah. So I think, MASALA has started to redefine some of our clinical guidelines by shaping, the screening practices for diabetes, dropping the BMI to a lower level. I am advocating more for completely dropping BMI from being part of the equation. For diabetes screening. We should just screen everybody regardless of BMI. And the better test to use for South Asians is a fasting glucose, not a hemoglobin A1C, because we know that hemoglobin A1C can be affected by different anemias and thalassemias that South Asians actually have more of than other groups. The MASALA studies also, worked hard to try to increase awareness through helping Representative Jayapal and her staffers draft the South Asian Heart Health Awareness Act of 2021 and 2023, and maybe in the new administration we'll have a chance to do that again. So, those kind of like public health awareness raisings, that's something that our study is very active and purposeful about. The big challenge I see is that we have to walk a very fine line between race-based guidance, ethnicity-based guidance, and race-agnostic studies, right? And thinking about it's not your, like I said, it's not your ethnic identity or race that is the equivalent of being high risk, because we know that there's a gradient, a distribution of risk across South Asians too. And so we can't just use our background to be like, you're high risk, you need to go on this medication. And so we have to walk this line very carefully and not suggest that, use South Asian ethnicity or Bangladeshi or Pakistani or Indian as a surrogate. And so I think we have to be a little bit more careful about what we mean by someone who's high risk. Is it their socioeconomic status because they can't afford medication, they cannot afford care, they cannot afford healthful food, they cannot afford to exercise because they're working 3 jobs? What is it about their social situation? What is it about their dietary situation? What is it about other stressors in their life? And we know that a lot of these factors can be modifiable if we have the right policies, if we have the right, ways of thinking about how to really change and modify risk over a population. And so I think it's really important that we drill down into being narrow in what we're speaking about. And that's why the current American Heart Association risk equations that help to risk stratify people based on high and low risk they're the PREVENT equations, and hopefully you've heard of them. these prevent equations are race agnostic. They used to before have, black and white based on the data that existed in these two groups. And now they are race agnostic, and instead they use socioeconomic status as a measure of your zip code as a measure in that equation. So they're trying to get away from just using like the fact that you are coming from a low income zip code means that you probably have a lot of these social drivers of health that are important for us to measure, even though we're not measuring all of them. This gives us kind of a surrogate measure. And I think the same way we have to be very mindful about doing that for South Asians. And it may not only be socioeconomic, it may end up being some dietary factors to be really specific about. Is like, what types of foods are you eating? What type of oil do you use? How much do you deep fry? These are really important factors that we know can impact health, and we just need to be more granular about them.
So, as the cohort continues, we as you're adding new sites, hopefully you'll be adding more sites, perhaps in Southern United States and others. We wish you more funding to add sites and continue expanding, so that you said you had there's one study in UK that has more than 10,000 participants. So hopefully your study continues to grow. So as the cohort continues, you're going to be probably discovering new questions to ask, and coming up with new findings. What are you more excited about to answer next? You already talked a little bit about the newest site that's been added in New York and the data that you're going to be analyzing. Are there additional areas you would like to add to analyze among these participants and future participants? What gaps remain that you still believe urgently need to be addressed?
Yeah, great question. So we don't know much about second generation or third generation South Asians in the United States. We don't know if these younger generations of our kids and grandkids are going to be healthier than their parents were at their age, or are more or less healthy than other second generation, third generation immigrants in the United States. So I think we really need to sort that out to be able to say that, we need to really focus our attention, because risk factors develop early in life. And so if we don't know what's happening in those younger populations, we will not be able to prevent the trajectory of their health over time. So Dr. Nilay Shah is at Northwestern University, and he's been doing a pilot study called a MASALA second generation study. And he's recruited about 150 adult children of our MASALA participants in the Chicagoland area to participate. And he's found some really interesting findings, and he hopes to expand that to all of our MASALA sites. So we're looking forward to learning more from that. I think women's health, the unique risk factors associated not only with reproductive health, but post-reproduction, like the menopausal years that are many more than just the reproductive years. So what do we know about, women's health issues over time? We know that South Asian women have the highest prevalence of polycystic ovarian syndrome. We know they have the highest prevalence of gestational diabetes and of other, poor pregnancy outcomes. And so what can we learn about this, and how can we break that cycle of mom passing on the risk factors to her babies? And that is a very active area of investigation that's being looked at in Canada and in India and other countries. And I think, MASALA needs to move in that direction as well. And the third is, how are people aging? In our study, to be in MASALA, you have to be between age 40 and 84. So we have people in their 90s and hundreds now. Several people who have made it that long in life. I mean, more than 50, 60 people have died already, unfortunately. But how are we aging? What are rates of dementia? What are rates of frailty and of disability? We know that, South Asians have lower lean muscle mass than other groups. How is that going to play out in the future? We know we have higher cardiometabolic risk factors. How is that going to affect our rates of dementia. We know that dementia is not being well captured in large health systems because we see data coming out of Kaiser that has aggregated all Asians together, showing that Asians have the lowest rates of dementia. But when we disaggregate those data, we see that South Asians actually have a lot of dementia. And so what are we missing here in, dementia that can we do something to intervene earlier in life? And so those are the three kind of broad areas that we want to, and we have grants, put in like 4 grants on the aging and have not been funded yet, but we're going for number 5 right now. And it usually, can take 5 grants to get something funded.
Yeah. I mean, it's so important to explore this. And I think you've been doing such great work in pushing all of this forward. And we're coming towards the end of this podcast. And so as we, come to the end and wrap up, given the evolving landscape of public health, your perspective has been invaluable to the next generation and people who are interested in these various areas. So given these unprecedented challenges in getting grant funding, in pushing forward some of this research that looks at equity and health, what advice do you have for emerging professionals or researchers who are entering this field?
Yeah. There are so many more people doing South Asian health research and programming now than there was 20 years ago. So we are very fortunate to have almost every city, every large, urban area has some initiative happening. So there are many ways to get involved and get experience and get mentorship. So I would say reach out to your local communities to figure out who's doing the work, what needs to be done, how you can help them get some experience. And then, I think the NIH grant situation is going to get tougher before it gets any better. And so we have to be a little bit more creative and clever in how we look for funding. So looking at small foundation funding, looking at other, philanthropic foundations that have been set up by South Asians to really help fund the initiatives that we are most interested in and working with the communities to find what is most important and relevant to them. So I won't give up hope because I know it's always been a struggle to get funding, and it still is. And it's just, we have to keep recreating ourselves and selling that important message. Is like, I think the message to sell is not that, oh my gosh, South Asians are so high risk, we need to understand more. That's not going to be a winning message for a lot of non-South Asians. I think what's going to be a winning message is that when we include everybody in research studies, we actually see the whole picture. We are missing a big slice of the picture when we don't include people who are different from the, majority population. So that's the avenue we've taken that has helped in obtaining funding over time.
Thank you.
Dr. Kanaya, we cannot thank you enough for this incredibly insightful podcast that I'm sure would be very beneficial to not just South Asians, public health professionals and clinicians, but also the audience. So thank you for sharing your journey, the insights, incredible lessons learned from the research and the impact the MASALA study can have and is having on policy, advocacy, clinical practice, etc. I'm making note of the fight test right now to ask my primary care clinician about it next month. Your work has transformed how we understand cardiometabolic disease in South Asians and continue to influence clinical practice, research, and public health nationally. So we look forward to probably having a part 2 conversation, next year, down the line when you have additional findings. Thank you. Over to you, Samira.
Yeah. It's been great, learning from you and just learning so much more about the MASALA study. And to our listeners, we were wrapping up Heart Health Month. Let's take what we've learned and turned it into action. Talk to your doctors about your health risk. Dr. Kanaya has talked about a lot of the different studies that are tests that you should do. So definitely make sure that you use that as a tool to advocate for your health. Even if you are feeling healthy, share this episode with your parents, siblings, and friends, and start conversations in your families and communities about heart health because knowledge saves lives. You can learn more about the MASALA study on the website. Our SAFA South Asian Research Hub also has a special link that takes you directly to the MASALA study website. You can explore the South Asian Research Hub on SAFA's website to explore different research articles and then also access our South Asian Cardiovascular Health Toolkit at www.safa.org. Again, Dr. Kanaya, thank you so much for joining us for this episode of the SAFA Spotlight Series. And to everyone else, make sure you follow us on YouTube and Spotify to stay updated on upcoming conversations throughout season 2. Thank you.
Thanks so much for having me. It was great talking to you.